If we go back to this is June 17th. What you're seeing in the blue, and this is from the CDC, anybody can go and look at this data, is these were the states where monkeypox was reported. Okay. That's July 26th, down 3,591 cases in the US. And this again was August 26th, so last Friday. Okay. And what you can see is that the darker the blue, the more cases that are presented. And on the CDC website, if you hover over this, it'll tell you the number of cases. And there's also a large table showing you. As of last Friday, there were 53. I saw 5 people this morning with suspected monkeypox. I think 4 of them have monkeypox. So I think that what we're seeing is now we are starting to see an increase in the number of cases, although we've lagged behind Florida, Georgia. I believe that we will continue to see more and more cases for the time being of monkeypox. All right. So I mentioned this before. Who is most impacted by the monkeypox outbreak? And what we're observing, not all, okay, but many of the cases were reported in gay, bisexual, and other men who have sex with men. I'll say this multiple times. Again, pathogens don't care about race, birth country, gender, or sexual orientation. There are pathogen factors, there are environmental factors, and there are host factors that come together to lead to the likelihood of an infection being transmitted, or a virus, in this case, being transmitted from one person to another. Complex, as you all know, studying public health and epidemiology, this is not a simple algorithm necessarily, or equation necessarily. So let's talk about transmission for just a second. What we observe, and this is thinking sort of in endemic countries and then non-endemic countries, is what we observe is that animals who are harboring the infection, humans come in contact with those animals, either direct contact, potentially also with live animals, also consuming or coming into contact with body parts of animals that are dead. The human then becomes infected, and that individual can then spread it to household or other close contacts. Okay. What we have seen, and at some point what has happened, is through travel, individuals have traveled to non-endemic countries, and through close contact, I'll get more into the specifics of transmission in a moment, others are exposed and become infected. Okay. Thinking about the way it's transmitted, really there are 3 main ways that we see transmission of monkeypox. It can be transmitted on respiratory droplets. Okay, respiratory droplets are larger, so I'm speaking. There are respiratory droplets that are coming out of my mouth and falling at a certain distance. It's a little different than airborne. Airborne is something that is on smaller droplets and can stay in the air a little bit longer. The skin lesions are infectious, okay? And we think that that's probably, or that is the main mode of transmission in this particular outbreak. It can be found in body fluids, okay? And we know that it's on contaminated surfaces and droplets. So bedding, towels, the virus remains viable and can be on those types of objects. And so if, for example, I'm sharing a bed with someone, certainly I'm in close contact with that individual, but it's also possible that I would become exposed, or if I'm sharing towels, things along those lines. We also know that the virus can enter the respiratory tract. So somebody it comes out on respiratory droplets, I breathe it in. That's less common in this particular outbreak, certainly through broken skin, through mucous membranes. And when I say broken skin, I'm not necessarily talking about a cut or something large. It can be very small, microscopic, that can lead to the virus getting into the body of someone who is exposed. We know in this particular outbreak that intimate contact, and really for any outbreak, has an impact, and that's for anyone. Anyone who comes into close contact, examples being oral, anal, vaginal sex, or touching of the genitals or anus of a person with monkeypox, it can transmit. And I think that I'll come back to that point, because we are seeing a lot of lesions on the genitalia and perianal, okay? Now, this is considered sexually transmissible. not necessarily sexually transmitted. So what does sexually transmissible mean? Well, if we say that monkeypox is sexually transmitted, we're removing all of the other ways it can be transmitted. We're saying it's not transmitted through respiratory, it's not transmitted on clothing, other things. We're saying it's sexually transmitted infection. What this says is one of the modes of transmission of monkeypox is through sex, or it's sexually transmissible. And again, it's a small difference, but it helps us remember that there are other ways. And it's important for us to remember that there are other ways that we can become exposed to monkeypox. Now, I said it's intimate contact. It doesn't need to be sex, okay? There are other mechanisms of intimate contact, some of them listed here, okay? And of course, talking closely would be more about the respiratory droplets. And I've given you another example of touching fabrics, shared surfaces, and objects that have been used by a person with monkeypox are potentially infectious. Yes?
How long does the virus stay on the virus?
That's a great question. So I'll repeat that question. That is, how long does the virus stay on fomites? The answer is we don't 100% know, but there was a study that was just done in England where they had a patient who was hospitalized for a certain period of time with monkeypox. What they did is they swabbed the room before and after cleaning, and they found DNA on most of the surfaces even after cleaning. Okay. Now, DNA is different than a viable virus or replicating virus. DNA just means we find the DNA. Okay, so more to come about the specifics of how long we do see that. So we don't 100% know at this point how long. Good question, and an important one for us to find an answer to, which will not only, it'll really help our patients and people who are potentially exposed, you know, to understand how to protect themselves and protect others as well. So thinking about the phases or the presentation, clinical manifestations of monkeypox, a couple of things I want to mention. First of all, if I'm exposed to monkeypox today, let's say, there's an incubation period. And that incubation period is typically 7 to 14 days, but it can be anywhere from 5 to 21 days, okay? And I have no symptoms, none. I feel fine, okay? Then what happens is after that incubation period, I also do want to note, this is important, is the person isn't contagious during that period of time. They then develop a prodrome. And what I mean by a prodrome, and it usually lasts about 1 to 4 days, but they have fevers, they have muscle aches, they have chills, they kind of feel like they have the flu or another type of a virus, okay? They may have a lymph node swelling, okay? And toward the end of this, many individuals develop a sore throat or a sore mouth, and sometimes even lesions in their mouth, okay? At that time, if you were to check their blood for presence of the virus, you would find it there, okay? Now, in classic monkeypox, that prodrome or that period of feeling ill is then followed by the rash, okay? And the rash will last anywhere from 2 to 4 weeks. In classic monkeypox, and you'll hear me say that multiple times because what we're observing in this outbreak is not classic, but in classic, usually they start in the mouth and then they spread to the face and the extremities. It can include the palms and soles with the hands. Okay, so let's talk a little bit more before we go into the recovery. Yes.
The rash, are we referring to the lesions also?
Yes. So I'm sorry, I'm using those interchangeably. The rash and lesions so the rash is kind of the idea of the whole presentation over the whole body. The lesion or the lesions are the specific spots or pustules. Okay. This is just reminding you in picture form of the presentation and the symptoms that we may see. Okay. If we look more specifically at the rash or lesion evolution, they typically go through several phases. Okay. They start out usually as kind of a dark or area of color change. They then will form a bump. Okay. They then form a blister. That becomes a pustule or a pustule blister. Sometimes they will have a divot or umbilication, a belly button in the middle of them, and eventually they will crust or scab over and heal. Okay, and it can take in the range of 14 days to go from here to here, give or take. Some people it may be a little shorter, some people it may be a little bit longer. Keep in mind that in classic monkeypox, all of the spots or lesions are similar size, okay? And they come up at the same time. Now that's important when we think about taking care of patients in the clinic and considering other things that cause pustules. Chickenpox, for example, causes vesicles and pustules over the whole body. The difference is it comes up in different crops at different times. So you'll have skin lesions that are in different phases, whereas in monkeypox, they're all in the same stage, same phase. Okay? We usually see anywhere from 10 to 150. They hurt, and then as they move more toward that crusting, scabbing phase, they usually itch and they're infectious. You will find virus in these lesions, okay? And so, and it's from the beginning, when you start to see the color change, all the way until that scab comes off and new skin forms, a person can transmit it. So in clinic today, for the patients that I saw with monkeypox, what I shared with them is the importance of staying at home, covering up those lesions, and understanding that close intimate contact can transmit it to someone else until skin is basically back to normal. Okay? Any questions about that? Yeah, please.
So if someone doesn't have a small cut, or even microscopic cut, and someone is fully drained, can they still be exposed if somebody is?
I'm sorry, say that again.
So what I'm asking is, can it penetrate through the skin without any cut in there?
So usually it is through micro abrasions, but very, 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 very small abrasions. I don't know the complete answer to that as far as how much of the virus you would need to be exposed and its ability to penetrate. But even just the friction of close contact is enough to allow transmission. So it doesn't take a lot, very, very little. Yes.
Is there a test available for monkeypox or is it?
Great question. I promise to come back to that. Okay, great. Over here, then.
Is this amenable to forward contact tracing?
We're trying. Yes, it is. It is.
So I heard that when you get the vaccine, you should disclose if you have a dermatologic condition.
That's correct.
Why?
That's a really, really good question. So we'll talk more about vaccines, but I'll give you an answer to that right now. Is that if a person has eczema or another condition, what we have observed with the vaccinia virus vaccine, which is what we use to vaccinate against smallpox, what we have seen is that sometimes with individuals who have skin conditions, that it will actually spread and cause them to have more skin lesions that are associated with the vaccination.
Is that infectious?
It is, and the reason why is because the vaccine that has been used, we'll come back to the sort of what we're using now, but the vaccine that is used is a live attenuated virus. So it is a living virus. And so people with skin conditions are at increased risk of sort of developing further skin manifestations. I took out the pictures from that because they're kind of sensational and they can be pretty severe when they happen, but it's important for individuals to share that information because it also determines the vaccine we give. Is it live? Is it not live? How do we give it? How do we protect people? So really good question. And I promise to come back to diagnosis. We got a whole section on it. Any other questions? Okay. So after the rash goes away, we do have this recovery phase. And I think this is important to mention. This is a self-limited infection. The body usually gets rid of it over time, okay? Now, and most individuals make a full recovery. Complications can occur, especially in individuals who are immunocompromised. And you'll see reported that the mortality rate is anywhere from 1 to 10%. Now, that spread and what we're seeing in this particular outbreak, yes, there have been deaths, but it's very, very rare. Now, the reason it's 1 to 10% is because there are two types of monkeypox. One with a lower likelihood of mortality, which is the one we're seeing with this outbreak, and one with a higher likelihood of mortality. Okay, so this outbreak is being caused by the one with the lower mortality rate. Okay, all right. So I didn't warn you that there were going to be pictures. There are pictures.
So this low mortality and high mortality are these different strains of the virus?
Yes. Different clades is what they're called. But yes, one has a much higher, that's the 10%. And again, what we're seeing with this particular outbreak is it's the lower one, and they can't switch back and forth. Okay. It doesn't work that way. It's either one virus or the other clade of the virus. Okay, now I'm going to show you some images. Okay, so this is from this outbreak, and this is some of the first information that came out of a clinic in Spain. And what they started noticing and reporting, and what we have seen throughout the United States is that prodrome in this outbreak is often less prominent. So people may not have fevers, they might not have chills, they may not even occur before a person has lesions. In fact, I've seen it where they actually occur after they have lesions. Okay, we're seeing a lot of genital, perigenital, and perianal lesions. We're seeing fewer of them, sometimes only one sore. And so the good news about this is that most cases are mild. The other thing to keep in mind is that they mimic up STIs as well. And so if somebody comes in with something that looks like this, okay, I might think now, wow, this looks like monkeypox. But if we were, say, 4 months ago and monkeypox wasn't a thing at that point, I might say, this looks a little bit like genital herpes. Or maybe it's syphilis, maybe it's something else. Now, we still need to consider those things when we're seeing our patients, but we also need to include monkeypox. And here are some examples. This is an example of one lesion on the genitals, a pustule with that center that's kind of a divot or inside. Here's another one. You can see a lesion on a hand. You can see multiple lesions here. A few more images. This is a case that was presented from, that was published in the New England Journal of Medicine early on. And the reason that I want to show you this is because this doesn't follow the typical pattern. The individual first noticed some sores around their anus, okay? And you can see some here, here, here. Then after a few days, they also noticed, or they noticed about the same time, a spot on their genitals, okay? What was interesting is that then the patient, after developing them there first, then developed spots on other places on their body. So the fingers, the hands, you can see on the shoulders. Remember what I said about classic monkeypox? They're all at the same stage. This is not all at the same stage, okay? So a little bit different. The other thing we saw, and again, I apologize sort of for the graphic pictures, but this is what we call proctitis. And what we're seeing a lot among people who have this is that we are noticing that they are having inflammation of the rectum, okay? A lot of pain with this. In fact, 3 of the 5 patients I saw this morning told me that they were having a lot of rectal pain with the infection, okay? So again, something we haven't necessarily seen previously. Here's another example. This is in a person living with HIV, published on the same date in the New England Journal of Medicine, but it's different. In this particular case, these were the sores that were observed in that patient. They also had this rash here that it was believed to be associated with monkeypox, but again, not something that we typically see. So what we've had to do is kind of broaden how we think about this infection and consider it even when it's not presenting in the classic ways that we consider that. Now, a word about clinical manifestations. One of the things to keep in mind is that fortunately, you're seeing relatively benign symptoms. But in persons with HIV who have low CD4 counts or their immune system is weak, in pregnant people, in people who are at the extremes of age, and individuals who have other immunocompromising conditions. For example, these are examples, maybe it's a person who has a liver transplant, we are giving them medicines to suppress their immune systems so that they don't reject their liver. But in those cases, we're also impacting the immune system, and that individual may not be able to fight an infection the way we would typically think that, or the way they typically would. And so we want to pay particular attention to individuals whose immune systems are not as strong, and carefully monitor individuals, potentially treat them with the medications that we have, which may, keyword right now, may help. As I mentioned before, we also have to think about other infections. And so I put these up here just to say that herpes can look like monkeypox and vice versa. Chickenpox, the same. Something called LGB, syphilis as well, and certainly molluscum contagiosum. So when a patient is coming in now with monkeypox, I think about those other things. And if they're coming in with something that looks like those other things, we think about monkeypox as well. And so what we need to make sure that we are doing to ensure that we are taking good care of the whole patient is test not only for monkeypox, but for other infections that can present in the way that monkeypox can present. The other thing I will mention is we're seeing high rates of co-infection with other STIs, okay? So for example, I saw a patient this morning that had monkeypox and gonorrhea, okay? And very, very frequently we see them together. And so if a person is coming in and we're thinking about monkeypox again, we want to ensure that we are doing the right thing and caring for the patient holistically, meaning thinking beyond monkeypox, and screen and treat for other STIs if we find them. All right, to your question, let's talk about diagnosis, right? Who needs to be tested for monkeypox? Well, this is what the CDC says. If you've got a monkeypox rash, you should get tested, okay? They also say if you have a rash that might be monkeypox and you've been in contact with someone else who has a similar looking rash, you should be tested. If you had contact with people who've been diagnosed with monkeypox, let's test you. And also, if you've had close intimate contact with people in a social network who are experiencing monkeypox activity, we should go ahead and test you. As well, if you've been to a country reporting cases and you have a rash that could be monkeypox, same thing. Finally, less common to this one, but something we do have to consider is if someone come into contact with animals or animal products where they could have been exposed and they have a rash, we want to go ahead and test them. So, yes.
Do you test positive during the incubation period?
No, good question. So the incubation period, well, no, because you have to, the way that we test is we have to swab one of the lesions.
So if you had close contact with someone who's been diagnosed with monkeypox, you wouldn't test positive until.
Correct. Correct. And one of the strategies in moving ahead is post-exposure prophylaxis with vaccination. So, and so if somebody comes into contact and you know, that is one strategy. So watchful waiting to see if you develop a lesion. And because the incubation period is anywhere from 5 to really 21 days, what we recommend for those for individuals is that they isolate and quarantine for up to 21 days. It's a long time. Yeah. Okay.
Any cases of reinfection after units?
Yeah, good question. So the first question is are there any cases of reinfection? Not to my knowledge yet have we seen reinfection. But you know, just like anything else, vaccination, nothing is 100% perfect. So I think that I think it will be rare, but I do think it's possible.
And then did mention if you got the vaccine before eczema, for example, if you can exacerbate their condition. No recognition about eczema, it's caused by some sort of like active immune system. So like in the case where it's very active arthritis or psoriasis and the be exacerbated.
Yeah, so you're right. It's different various, we see it usually mostly with eczema. So the question has to do with, do we only see those changes that you were asking about potential risk of further skin infection with eczema? You're right. We potentially could see it with the others as well. And oftentimes people who have psoriasis or other skin conditions may be on immunosuppressants as well because it is inflammatory. And so we would want to take caution in individuals with how we approach treatment, or excuse me, how we approach vaccination. Yeah. Fair enough, fair enough. Any other questions? Okay. What a good question. We don't know as much about that and transmission through pregnancy. So I haven't seen or heard of any cases of transmission through pregnancy, but I need to do a deeper dive into that. I haven't seen it. Doesn't mean it hasn't happened. I just haven't seen it.
And but the patients are not infected during the incubation.
That's correct.
You know what type of antibodies that we were advanced to by Monkeypox, IgM?
So all of them, so IgM and then IgG would be produced more. I don't know as much about IgA and others that are found in mucosal membranes because this is not necessarily a mucosal infection as much.
From what I understand, T-Pox was approved for like emergency use, right? Why isn't it FDA approved?
Well, it's not FDA, so it hasn't been shown. Actually, can I come back to that? Because I'm going to talk about T-Pox in a second, and I think it'll make more sense if I talk about it in that context. But you're right, it's emergency use right now because it's not FDA approved. So yes, I promise to come back to that. So coming back to diagnosis, early on, basically, the way we it was a two-step process because we didn't see that many cases of monkeypox. And so the CDC said, okay, we've got these centers all around the country. They're called laboratory response networks, and they have the tests for orthopox viruses, which is and we can detect whether or not somebody has an orthopox virus. But as I mentioned before, there are tons of orthopox viruses. So if somebody's positive, then what happens is they send a sample to the CDC. The CDC does a confirmatory test, which is a PCR. That's how we're doing the test. PCR, and if it's positive, it's monkeypox. Well, a lot has happened really quickly, okay? So that was kind of the strategy in May and June. But the CDC and the health officials realized that we were going to have to expand pretty quickly. And so basically, the CDC sent their tests to all of these different labs. And over the course of July, these different labs came online to be able to do monkeypox testing, PCR. So basically, if somebody has a spot, a pustule, I will swab it, and you swab two. But anyway, I will swab it, and then you can send it to the lab, and they will go ahead and do PCR tests. So the testing capacity now is about 80,000 tests per week in the US, okay, at these labs and at CDC. As well, just information about UAB, monkeypox PCR came online August 18th, so we can do it in the hospital as well, okay? And we are not sending out to these clinics, but directly to our hospital, which is great because the turnaround time for getting those results is much, much shorter. So coming into the treatment piece, most cases are mild and they really don't, all they require is supportive care. Tylenol, ibuprofen, sometimes numbing medicines for the throat, and things like that are what we need. But there are some treatments that are available, okay? As I mentioned, most commonly supportive care. But there are antiviral medications that have been used, okay? Brincidofovir and tecovirimat. Tecovirimat is taking hold more than brincidofovir for reasons I'll show you in just a second. We also have vaccinia immunoglobulin, or antibodies from people who have been exposed to vaccinia that we can give to a person who is infected, and it can potentially shorten the length of infection. We also have vaccines, okay? The live attenuated vaccine, or the live vaccine, is called ACAM or ACAM 2000. The live non-replicating, i.e. the one we want to use in individuals who are immunocompromised, individuals who have skin conditions, is not replicating. That is called genius, okay? So let's talk a little bit about potential treatments. If you want to read through this another time at your leisure, feel free to do that. But what I'm doing here is just showing you the different medications, their mechanism of action, how they're dosed, and their FDA approval status, and then side effects. Okay, again, this is just for a high-level overview, but you have that if you want it. Coming to your questions, okay, let's talk about the treatment, then I'll answer this. So we really don't know if it works or not, if our treatments work. We haven't had time to really see, okay? There's been only limited publications, and this was a study looking at monkeypox, a retrospective observational study, and it was done between 2018 and 2021. Now, remember, we occasionally do see monkeypox coming out of endemic areas and people infected. And basically, by looking back at hospital records, they found people who had been infected with monkeypox and they received either the brincidofovir or the tecovirimat to see if it helped any. No control groups, okay, really. Oh, not a great study, just going back and looking and seeing, did it work, did it not work? And so this is the data. They had 7 people, okay, not a ton, 7 people who participated. And 3 of those individuals were treated with the brincidofovir. All of them developed liver trouble and had to stop the medication. So we're not going to use brincidofovir, okay? What about the tecovirimat? N of 1, okay? 1 person got it. And they got 600 milligrams twice a day for 2 weeks. No adverse effects, which is good. We first want to do no harm. And what they observed is there was a shorter duration of viral shedding and illness. They were in the hospital 10 days compared to the 6 other patients that were in the study. Okay, so again, not a well-controlled study, but what they're saying is this one individual wasn't as sick as the others. I went back and I looked at the characteristics of this individual. When they came in, they also had fewer lesions and didn't seem to be as sick. So I don't know if tecovirimat works or not, but what we know is it appears to be safe. So this is the first study. This was published the 22nd of this month, and it looked at compassionate use or emergency use of tecovirimat for the treatment of monkeypox. And this was used between June and August. Again, non-controlled. You had to have monkeypox. If you had monkeypox, we give you 14 days of tecovirimat. They could extend it if they needed to, and then they followed those individuals at day 7 and 21. This is the patient information, just so that you can see a little bit of this. All were male. The median age was about 41. 9 of the individuals were living with HIV, and some had received either the vaccinia or Jynneos vaccine. Symptoms were pretty typical for what we're seeing in this outbreak. Percentage-wise, almost 100% had lesions. About half had fewer than 10, and then you can see fever otherwise was the most common symptom in this population. What they saw is that by day 7, 40% had complete resolution of their symptoms, and by day 21, 92% had complete resolution. Medicine seemed to be well tolerated. There was no discontinuation of the therapy, and you can see the adverse effects that patients reported. The problem with these adverse effects are they're also the same symptoms people have with monkeypox. So we don't know if these are true adverse events or not. And so the conclusions from this are limited. Tolerated, unclear if adverse events were related, as I said, and no ability to assess benefit. So that's what we're working with. So now coming back to your question, why is it not FDA approved? Because we have no proof it works. And so in order for a medication to be approved, we need that data. So because this is an emergency, and we hear, it's considered an emergency, a health emergency, we can then use medications under the Emergency Act for compassionate use. So, for example, when I prescribed tecovirimat twice this morning, I went through informed consent with the patient and helped them understand the limitations of the medication. And we had a conversation about whether they felt that it was right for them. Okay. More to come on that, I'm sure, very, very soon. Okay. Let's turn to vaccination for just a second. Okay. What we know is that infection with Monkeypox virus does confer cross protection between other viruses. I mean, we can go all the way back to in early days an understanding of cowpox and people who were milking the cows were not getting smallpox. So that was an early example of cross protection. That's why we use the vaccinia virus. That's not, or we use basically we're using a different virus to vaccinate against smallpox. And in this particular case, we are using a different virus, injecting with a different virus that we believe will offer and does offer cross protection against monkeypox. The data is better here, okay, that it actually works. Now there are two. The ACAM 2000, as I mentioned earlier, is live replication competent. Jynneos is the one that we are using most right now and has been distributed. This is a non-replicating modified virus vaccine and appears to be well tolerated. And both are approved for persons who are 18 years and older. So what's the national strategy for vaccination? Well, this is phase 1, okay? This is June. The idea is we've got these stocks, we got to get them out as quickly as possible. We're going to give the vaccine close contact with people known to have monkeypox as a post-exposure prophylaxis, or hopefully to prevent them from getting it. We'll also try to reach persons who are high risk or have high risk exposures where we know that monkeypox is actively spreading. And this is a strategy called PEP. Okay, again, I know I've said post-exposure prophylaxis, but I'll talk about PEP plus in a second. So again, this is administration of the vaccine to persons who have been exposed to a disease in order to prevent or lessen the severity of the disease.
Nick, one quick question before you go to the next page. So are you seeing any patient who has been vaccinated with smallpox vaccine?
We have seen, not in our clinic, but we have seen people who have been vaccinated with it, but it's still very, but that's like in the past. That's not during this particular outbreak, except in certain circumstances. Let's say it's already incubated, okay, and I get post-exposure prophylaxis. The virus may already be to that point where it's going to manifest, and that post-exposure prophylaxis isn't going to help because I've already had it for an extended period of time. So more to come. We think that it has about an 85% protection rate, okay? And that's based on older studies looking at people who've gotten smallpox vaccine in endemic areas, and then were exposed to monkeypox, and the percentage of those who actually developed monkeypox. And again, it looked to be about 85% protected. There's another question.
In the previous slide and before you talked about the live replicating and the non-replicating, what are the pros and cons of those, or in what situations would you use one and not the other?
So in this particular case, so replicating viruses should not be used in immunocompromised individuals, okay, because they can kind of take hold and cause trouble. Replicating viruses, though, often develop a better immune response, a higher immune response, and so that is sort of in general terms. There are more factors, but that's in general kind of the big difference. Okay, so phase 2 now, July. We have more vaccines that are distributed, and what the CDC and Human Services is doing is saying, okay, we need to get the vaccine to places where it's really needed, and so you would see it going to certain places than others. And the strategy was then PEP, as we talked about, but also PEP plus, and PEP plus is a post-exposure prophylaxis with an emphasis on vaccinating persons at high risk of exposure in the absence of a known exposure. Okay, PEP, I know I've been exposed. PEP plus, I have a high chance of being exposed. And so with more vaccine, they said, okay, we can do PEP, but now let's do PEP plus and see if we can get it to people who have have a potential vulnerability. And phase 3, which is where we are, and as we are going, as more Jynneos vaccine becomes available, we'll be able to implement it broader and broader. So the vaccine, again, it's been approved for protection against smallpox and monkeypox. It is good for people or has been approved, I should say, for people 18 years and older at high risk for monkeypox. It says its effectiveness is not known of Jynneos. What I was talking about earlier was in general monkeypox or smallpox vaccination and protection against monkeypox. It's a 2-dose series, 4 weeks apart, and we know that Jynneos non-replicating can be used in individuals who have immunocompromising situation or conditions. So Jynneos vaccination was approved for subcutaneous injection, and you had to use 0.5 milliliter. Okay. There's also something, you may have heard this, what they're doing now is recommending that we do it intradermally rather than subcutaneously. There are a couple of reasons for that. One is based on a study that was done in 2015, which showed us that if you give the injection of the vaccine intradermally, just under the skin, it's as effective in boosting an immune response as if you give it subcutaneously. Okay. The good news is also, if you do it intradermally, you only need 1/5 the dose. So 1 dose now becomes 5. Okay. So this is what is now recommended. Now, what we do see is if you give it under the skin, we can see more redness, firmness, itching, swelling at the injection site, but it's less painful overall. Okay. And so basically, as of August 9th, this is what was said by basically the FDA, that circumstances exist justifying the emergency use of vaccines. The FDA may use this Emergency Use Act to allow emergency use of unapproved vaccines or unapproved uses of approved vaccines. So the intradermal injection is an unapproved use of an approved vaccine because it was told before you got to do it subcutaneously. Okay. All right. So who should be vaccinated? We've gone through this, and because we only got 4 minutes left, I'm going to go ahead and move ahead just to say that more than 634,000 vials of Jynneos vaccine have been distributed, and it's anticipated that 1.9 million vials of the vaccine will be ready later this year, and another 2.2 million early on. What about Jefferson County? So what is Jefferson County has the vaccine, and if you go to their website, this is what you will see. And they designate that this is for persons who had an exposure to a known case of monkeypox in the last 14 days, persons who work in a laboratory setting, who deal directly with monkeypox samples, and also persons who are gay, bisexual, trans, gender nonconforming, gender non-binary, or other males who have sex with other males, and also persons who engage in sex work are eligible for this. And a person can call this number, get set up, and go get the vaccine. Okay. Now, there's going to be a lot of ongoing surveillance. We don't know if it works. Okay. Vaccination, we don't know if the medication is very effective. So expect changes in what I'm telling you today. And also, remember that the CDC actually does a pretty good job of keeping its site updated to make sure that you have the most up-to-date information. Because we only have a couple of minutes, I'm going to end on this. Queer communities suffer a lot of stigma. And this is an example of another infection that we're seeing at higher levels among people who are members of the LGBTQI community and people who aren't, okay, as well. So how do we address this and do our best to do it in a non-biased way? Well, the first way is to try and use a health equity lens to be inclusive and to avoid bias to reach patients. So what does that mean? Things that you know very well. we need to think about not only a person's health in terms of their physical health and what is happening at that level, but also systemic social and health inequities and how those impact not only a person's likelihood of coming into contact with monkeypox, but also accessing care and willingness to access care. We also have to recognize and reflect the diversity of the community as we try to address this. So we need to use accessible language to the communities that we're working with. And also we need to tailor our communications in such a way that we are addressing the unique circumstances of our patients. And finally, we have to realize that health equity is intersectional. And so when we're working with patients who are here with monkeypox and perhaps are gay, bisexual, other men who have sex with men, we have to understand that there are other layers that or intersections with other factors that impact their health and their ability to access health. So when communicating about monkeypox, and I think this is something we all can do, we need to recognize and describe it as a legitimate public health issue that's relevant to all of us. Okay, it's relevant to all of us. It's not a gay problem. Okay, it's a problem for all of us. We also need to think about providing factual information to our patients and to others. We've talked about all of these, but again, that factual information is important. And finally, sorry, I'm moving quickly through this. We need to think about how we frame monkeypox through the language we use. We need to think about even the pronouns. We talk about it. We are at risk for monkeypox rather than you and gay people, something that I cringe at even saying, but saying, for example, are at risk for monkeypox. We also want to be careful about the language we use. We don't want to be over sensational about things, and we don't want to show those extreme images that really sensationalize it, okay? We need to think again about our audience and concepts that are important to them. We also need to be positive in what we're saying. I think that we have, with monkeypox, not only do we have a lot of tools and we're empowered, but also our patients are empowered to take action that will protect themselves and protect others. And so we want to emphasize those strategies and really minimize the fear that's associated with it and focus on the self-efficacy and personal agency. Finally, what we want to do is we want to work closely with our community partners to help ensure that our information is collaborative and cooperative, and we are understanding the perceptions of our community partners about monkeypox, and also working with our community partners to be able to distribute that factual information. So I'm going to stop there. Just say we're up to the challenge. Monkeypox is a challenge, but we're up to it. I want to thank everyone here for being here and also for the work that you do to help the health and the well-being of others. The work that you do is incredibly important. And finally, if you have any questions or thoughts or comments, please feel free to email me. And I'd be happy to stay up here for a few minutes afterwards. Sorry, it's 1 o'clock. I'll stop talking. Thanks so much.